Case 1. So we start with a young woman, 44-year-old, with a nipple discharge. And this is the core biopsy of this patient. The cores show fragments of a cellular proliferation, very blue. There is some blood here. Here it seems that there is a portion of the duct wall. There are annotations, okay. So here is a portion of the duct wall that does not seem infiltrated by any tumor. It's lined by a very thin strip of epithelium, kind of flattened, while here we have all these florid, very prominent fragments with a lot of epithelium. That to me already is consistent with an intraductal papilloma, or at least suggestive, because if it were a carcinoma, there would be more proliferation also along the wall of the duct, while finding a flattened epithelium means, in my imagination, that this is an intracystic lesion that has grown inside the duct for such a long time and has compressed the epithelium lining the wall. So that's already makes me think we have an intraductal papilloma. And then all these other fragments are detached. We see nice long fibrovascular cores right here. And the fibrovascular cores are lined by 2 layers of cells, the luminal cells, columnar, the myoepithelial cells. They're kind of prominent. Is this an adenomyoepithelioma? I don't think so. It seems to be entirely intracystic. So I favor, still this morphology makes me favor an intraductal papilloma. There was an area right here where we have this, proliferation of the epithelium, but nowhere looks atypical. This looks like fragments of UDH, areas with UDH. Here is another area where there is again a proliferation of these cells. The nuclei are slightly enlarged, but haphazardly arranged. The outline of these cells is the cell membrane is somewhat irregular. There is some folding here, a more irregular triangular shape. So here is a pointy shape, very triangular. So to me, this all points to a benign ductal proliferation with minimal UDH. Here is another area. There are micropapillae here. They are a little crowded. There is this a bulbous micropapilla? I don't think so. It has a suggestion of a bulbous outline, but if you look at the cells, they seem to become darker. The nuclei become darker and more hyperchromatic as they move away from the wall of the acinar space, and the nuclei are overlapping, and there is no polarity at the periphery of these micropapilla. So this is, I think, a micropapilla of UDH, same thing here. So the proliferation here, there is no real complexity. This could raise the differential diagnosis of focal ADH, but there is no nuclear atypia, and there's too much overlapping. There is no rigidity. And I think I have another slide for this case. This is an ER stain that show pretty much the same findings that are consistent with what I just discussed. This looks like the normal distribution of ER positive cells in normal ductal epithelium in a papilloma. Very flat, linear, even in these areas where there is more epithelial proliferation, there is not much ER positivity, and it's heterogeneous. Some cells are darker, some cells are paler, so UDH. And then here is another stain. This is a beautiful example of CK56 staining that weakly stains the myoepithelial cells. I also don't use CK56 much as a myepithelial marker, but it has that added benefit in some cases. And then has this mosaic pattern in the UDH. And I don't know if I have another focus, but one can, cruise around and it has the same kind of arrangement here. I didn't look at this part, but it's probably an area of sclerosis that has emerged in the deeper section where the papilloma is growing within, attached to the duct wall. And I don't think this qualifies as invasive. Actually, we can go back and look at the previous focus. There is no invasive carcinoma in this case, I hope, because it was called the papilloma. Yeah, no, there is no invasion. This is ER staining. It would have been, with that blend morphology, would have been all ER positive. So there is no invasion in this case. This was called the papilloma. And because the patient had symptoms, actually, I do have the excision, and I know there is no invasion. This is a beautiful example of a papilloma that is within a duct and has, like it's composed of 3, 4 fronts that are all nicely kind of fitting with one another. And in one area here, there is more stromal fibrosis. That's probably where the duct, the point of insertion, this fibrotic area. We see the same epithelium. In some areas, the fibrovascular pores are hyalinized. And this is, again, a nice example of papillae with myepithelial and epithelial cells, no atypia. So I think the first case diagnosis, there is more of the same papilloma, very large lesion, I guess, that is all growing inside the duct. And in some areas, there is more sclerosis here. Actually, this one I do remember. And that's why I pointed it out, because sometimes, especially at the point of insertion of the papilloma, you can have the glands that grow, seem to grow into the wall, mimicking invasion, but it's still confined, within this rounded outline. It's not through invasion. And again, as written in the note, the stroma is eosinophilic. This is not a desmoplastic stroma that you find in cases of invasion. Here is another area. Sure. No, I generally don't use that. If sometimes I say no invasive carcinoma is identified if I want to be absolutely clear. But otherwise, I describe. I rarely use that term. Do you use that term? No. Yeah, something like that. Because I think it generates more confusion than, so I don't use it. There is one area here where the epithelium is very, distorted, probably secondary to cautery. There must have been some cautery. Something happened to this epithelium. It's all liquefied. But I didn't think that there was evidence of atypia in this focus. And again, it's really difficult in a case like this. One could do immunohistochemical stains, but then interpret them only if they work. If I do CK56, it doesn't work. Well, is it because it's atypical or because it didn't stain, right? The tissue is poorly preserved and didn't stain. So sometimes one makes a judgment call. I didn't think that there was enough, there was evidence of atypia in this case. So I called this lesion a papilloma, and that is the excision of the previous case. Any questions? No. Yeah. No, unfortunately. But they do them for prostate, but they don't do them for breast. So it would have been very nice to have them, but no. They say prostate is easier to cut because it's all nice and hard. And tissue, you know, has a similar consistency. Breast is too fatty. It would take too long for the technicians to do that. At least that's the explanation I've been given. And we have a lot of cases. So do you? Yeah, you have to get your technicians. Yeah. That is fantastic, but I don't have, we don't have that luxury. The next case is another patient with a core biopsy diagnosis of papilloma in 2013. That's when we published our series demonstrating that the upgrade rate of papilloma was very low and there was no need to excise if there was no atypia. Well, this case was diagnosed in 2013 without atypia. The patient did not have excision. The papilloma was followed and grew from 1 centimeter to 2.8 centimeter in 2020. So we took it out at that point, and I'll show you first the core biopsy and then the excision. I always get concerned when I see these cases, right? Were we wrong? You know, and is it safe? There is actually some literature looking at the follow-up of papillomas that were only followed by imaging without excision. And it seems, no, I don't. I can give the information. You're right. I think she's probably in her early 50s, something like that. Typical age for papilloma and breast cancer. So this is the core biopsy we received compared to the previous core biopsy. Well, again, detached fragments of a very cellular proliferation that is once again centered around fibrovascular cores, a lot of epithelium. And I think, as I wrote here, to me, this proliferation has more the features of very florid UDH. Here is another area. Again, if we evaluate the space between two adjacent fibrovascular cores, this is a focus of UDH. So we can break apart this proliferation everywhere and apply the simple rule that I told you. It all looks like UDH to me, right? Here is some more in this area, for example, one fibrovascular core, another in between, it looks like UDH. So let's see, here again, some complexity, but again, it doesn't have the rigidity or of BCIS or ADH. I thought it was all ADH, very florid in this case. So we called it, actually, we did also some stains. And the stains here, kind of, there is more ER positivity, but it's still than in the previous case, but it's a bigger lesion, a lot more epithelium. There is really no uniformity in the ER positivity, kind of a scattered heterogeneous positivity, to me, still consistent with with UDH, a lot more. And then here is CK56, I bet, and it has the same mosaic pattern, a little bit more florid in this case, but again, is consistent with UDH. So once again, we call the core biopsy UDH. So what happens next? Well, the tumor is, the lesion is way too big, so we wanted to see it out. It was taken out. And there it is, again, another cystic duct that contains this big proliferation, right? Here is the benign breast parenchyma around it. And I went to, here is the bulk of the lesion that, again, consists of detached fragments. Many times it's hard to evaluate papillary lesions because they all fall apart, right? And here, the cells are a little bit plump, a little bit more plump than in the previous, in the core biopsy. But to me, again, they have no architectural complexity. They have irregular nuclei that in some areas have a more clear chromatin, inconspicuous nucleoli. The nuclear size varies in shape, varies, and they also vary in shape, and they are overlapping. There is disorganization essentially in this proliferation, and there is no true polarity anywhere. The nuclei are really abutting the luminal space that is residual in some areas. So I thought here is an example of adjacent fibrovascular cores, and the space in between to me looks like UDH once again. Here is another area, and here is another slide. This time we have ER again. There is again more positivity for ER, as we already had noticed in the core biopsy, that it's quite positive, but still there is no homogeneous positivity and of the epithelial component as we would find in a DCIS or even in an ADH. Here, this is the most probably questionable focus, where there seems to be more complexity here. And maybe there is a suggestion of cribriforming. But if you look more closely, there are actually epithelial other cells in between. There are myepithelial cells right here. They're not staining for ER, but they're present. So it looks more complex, but I think it's because of the nature of a papillary lesion. Even here, there is, it looked more complex, but there are myepithelial cells. These are small glands. Focally, maybe there is a focal initial complexity, or it could be secondary to, you know, the cutting of these papillary fronts. So I didn't think that there was enough atypia to call this ADH. Do you agree?
So I was just going to say that I think you have to be careful in terms of the ER, it's a single.
Yeah. And do you agree?
I agree with you. Yeah, so it's like.
Yeah, and there is a lot of it, but once you go closer, you can see cells that are not staining. It doesn't have that rigid architecture you would expect in ADH. Yeah, in this particular case, in this particular slide, there is no evidence. Here is more of that linear pattern that we saw in the first case that is unrelated to this one. But again, even though there is a lot more epithelium positivity for ER, I don't think anywhere it qualifies as ADH. And I think I have also a UDH, sorry, a CK56 stain. And again, in some areas, and that's why I was pointing to this focus, because this focus looked, you know, in the ER, there is some positivity. In the CK56, it looks not as positive, but I think there is still positivity. And here, there is no complexity in this architecture. As a matter of fact, I think that these, you know, I can even see my epithelial cells in these areas with my own eyes without immunohistochemical stains. I don't see any complexity in this case. So we called it papilloma once again, and we're happy. This is the P63. Oh, I have also P63 in the same area. And again, there is nice positivity with, you know, the pattern here of the epithelium seems to be more irregular with the frayed edges, more like in usual ductal hyperplasia or usual epithelium. So we didn't call this atypical. Even in 2020, I was very happy that we didn't make a big mistake. You know, just an example of what happens to a papilloma without atypia. If really there is no atypia back then, and you gave a right diagnosis, they probably continue to grow. Now, my approach would be to take out all masses in the breast, but right now there is a more conservative approach that the surgeon and the patient alike, I guess this patient was willing to have a large size lesion, 1 centimeter in 2013, and waited, you know, 7 years when it tripled in size to come and get it out. So this is the natural history of the papilloma. Another patient, 50-year-old with an abnormal mammogram. This case you may recognize because you have already seen this focus. This is a case called elsewhere, atypical, actually intraductal papilloma without atypia, but is clearly atypical. The chromatin, the nuclei are similar in size. The cell border is very sharp. The chromatin is very fine. When I discuss ductal atypia, I usually say that the nuclei of a typical ductal epithelial cells remind me of carcinoid nuclei. So if I look at the tumor, epithelial proliferation, and I see nuclei that look like the nuclei of a carcinoid tumor, I think this must be atypical. And in carcinoid tumor, the nuclear contour is very smooth. The chromatin is very fine. It's not as salt and peppery, but it's very homogeneous, inconspicuous nucleoli. That is quite useful, at least in my practice. Here is the excision. So that we call the atypical. And this is the excision. And the excision clearly has DCIS. That in some areas, you know, grows on filiform papillary fibrovascular cores, very delicate. In some other areas, you can only see a small, you know, red blood cell suggestive of a fibrovascular core. But this is an example of more papillary architecture without visible myepithelium. There are some areas in this lesion where I thought I could see my epithelial cells. And, you know, that is always, raises always a question, maybe not this area, whether you can have myepithelial cells in a papillary carcinoma or not. But this is one of many components. There is this cribriform micropapillary in some areas. So just to demonstrate that case needed to be excised. And here is the ER stain. I've made, you know, these slides will be available to you in the interest of time. I'm going to move forward. At what time are we supposed to end? Okay. So actually the original diagnosis was UDH and secretory changes. I couldn't see anything secretory. And the correct diagnosis was papillary ADH and the excision showed the papillary DCIS. Another patient with an abnormal mammogram. And again, we have another papillary lesion. This one, you know, the epithelium is clearly atypical, hyperchromatic nuclei. There is a cribriform type of arrangement, at least in some areas. So no evidence of myepithelium along this, you know, covering this fibrovascular core. And this is another example in a core biopsy of there is an area of necrosis, clearly a bulbous projection, bulbous micropapilla. This is an example of papillary DCIS, not only papillary, because some areas have, you know, cribriform and more spindle cell appearance, but in a core biopsy. And then I think these are all the features. There is no invasion in this area here. There is this irregular, you know, this reactive stroma. I always, as I'm sure you all do, focus on these areas, wondering, is there invasion? is that microinvasion not too convincing and probably not present in the deeper sections. So we call this DCIS. And this is the excision. And the excision also has consists of carcinoma. It seems to be very circumscribed. Here is the biopsy site. And there is clear-cut DCIS that involves a few small ducts reforming right here. And then there is a larger area. Actually, when I was looking, this case was called DCIS, but when I was looking yesterday, it made me wonder, you know, looking at the slides again, made me wonder whether there is an incipient encapsulated papillary carcinoma in this area here. So here is the DCIS. Here is the DCIS with the hyalinized fibrovascular cores. And this is the area that I was saying yesterday made me think, well, maybe we didn't call this as, should have mentioned the features suggestive of EPC. They are, seems to be encapsulated and there is, as I wrote, I couldn't tell if there was myepithelium around this at the periphery of the lesion. Luckily for us, if we missed an incipient EPC, there is no impact on treatment or the, you know, staging or diagnosis. So, as you know, it's always dangerous when one goes back to look at all cases classified as X. It's like, oh my God, there is also Y. You know, in the big scheme of things, it didn't matter. But today, I wonder if there is a component of EPC. So this is the ER staining, just to contrast with the previous staining in papillary lesion. Every cell is staining here. Although I'm always reluctant to say 100% nuclear staining, I always say 99%. But so we call this papillary DCIS. Really, maybe there is a component of EPC. And this one, though, will be a true EPC, 75-year-old retroareolar breast mass, beautiful nodule, clearly encapsulated. The capsule is actually quite thick. It's very, you know, friable, falling apart. That's very common in this type of papillary lesions. The filiform fibrovascular cores are very delicate and can barely sustain all this epithelial proliferation. And the epithelial cells are monotonous, similar. The nuclei are small, so I would say low nuclear grade. And then we go to the capsule. Let's see if I have notations here. Here is a low nuclear grade atypia, very filiform, delicate papilla. Here again, monotonous proliferation, no myepithelial cells. Here is an area that has a more cribriform appearance, again, nuclear monotony, uniformity. And at the periphery, the cells seem to be resting directly on the capsule. There is no intervening myepithelial cells in the cells above the stroma. And there is one area here that looks like could be the beginning of invasion. It's interesting. I can read from here. They appear to be minimally infiltrating the capsule, but then there is no breaking through the capsule. So this is still an EPC without invasion. And sorry. Sorry, I'm going here. Let's find it again. Here. Yeah, I don't know if there was a biopsy. It doesn't look like here. The hemosiderin, as you know, these papillary neoplasm tend to be really delicate and sometimes bleed even if there was no prior manipulation. So finding hemosiderin not necessarily pushes me towards prior procedure. I don't know, maybe there was, but I don't know for this specific case. But good point. And here, oh yeah, This one is a focus where there is, it seems to start to be invasive. This is highly suspicion for invasion. These single little glands could be a well-differentiated early tubular beginning of a well-differentiated carcinoma. Is still inside the capsule. We didn't call this one as invasive. If these cells, glands were outside through the capsule into the fat, we would have called it. What do you think, Laura? Would you have called this invasive? Okay. So you see differences in opinion. If you apply strictly the WHO criteria, this is still in the capsule. It's a conventional pattern, but it's in the capsule. And actually, it's not uncommon to have, changes that are limited to the capsule. In theory, it should be out. This one is very suspicious, but I didn't call it. And, anyone would call this case invasive?
Very tough case.
Tough case.
Very tough.
Yeah, very tough. So I called it encapsulated papillary carcinoma. Then I have another case. Oh, this is also interesting. Another elderly lady, 70-year-old. She had an excision of an infarcted retroareolar papilloma 2 years before. And she now presented with another mass in the same area. Very suspicious history, right? And here is the mass. And this is actually not the current mass. This is the mass from 2 years before. This, given the type of institution where I work, many times we receive a case, but then we receive all the prior slides. And that actually is interesting, makes a nice story, nice way to review the entire case. This is the original diagnosis case called papilloma. Very necrotic. And there are some epithelial cells at the periphery of the lesion. So here is the necrotic tumor, really hard to make any sense out of it, except that it's all necrotic. However, in these necrotic areas, you can still see the nuclei are dying all with the same size. I don't know how to say it. They all look still very uniform to one another, right? Quite remarkable monotony in these nuclei that are residual about to die. Some of them still look viable and look very somewhat atypical in a way. And then there is this large area of necrosis. And in a case like this, I always would go to the periphery of the lesion if I manage. No. Okay. Where there is some residual viable tumor. I told you before, typically a papilloma grows inside the duct. The epithelium at the periphery is very flattened. And if anything, you get a tiny flattened strip of residual epithelium. Here, there is residual epithelium, not yet necrotic, but it doesn't seem to be in a strip-like arrangement. So that makes me suspicious that, it could have been, these cells are have enlarged nuclei. Could this be a typical, I don't know. Let's see if we find something else. And I have another slide, very similar, very necrotic. Notice the thick capsule. Again, in a thick capsule could occur in a papilloma. The duct can become quite thick, but can also occur in an encapsulated papillary carcinoma. And there is epithelium here too, quite, we don't see the point of insertion of the papilloma with the sclerosis that I showed you before. This is residual viable epithelium. And actually in one area, there seems to be almost like early infiltration into the capsule. Again, it infiltrates, it seems to be present into the capsule, not outside of it. And, all these features make me somewhat, here is another focus, too much epithelium along the wall. I would have done a ER staining probably. I actually did work up this case for interest, and I can tell you the cytokeratin is very positive and ER is positive as well. Unfortunately, the slides were not scanned. And I want to point to this area where the epithelium is starting to necrotize, but I'm sure you can see it is organized in a nice nest, and there are almost like, this is a suggestion of some capillaries at the periphery. This could be from a carcinoma, an encapsulated papillary carcinoma. Then this is the new tumor that developed in the same area. This is again a papillary lesion. And the nuclear atypia is very similar to those areas we found at the periphery of the tumor. So it's kind of low to intermediate. And, you know, same kind of arrangement as I showed you, cribriform area right here. And this more solid and focally cribriform arrangement. This is, you know, with this much epithelium, no myepithelial cells around this nest, this is a focus of carcinoma. And indeed, this was a carcinoma with still features of an encapsulated papillary carcinoma. But in some areas, even though it's technically not outside the capsule, we thought it could be invasive. And here is, you know, it's always difficult to evaluate these lesions. And definitely, I don't know if you know, it looks very large, very complex. Definitely an EPC, is there invasion here? I think there is one other area where there was a suggestion of invasion, maybe in the previous slide. Sorry for that. Here. Also here, it looked like kind of irregular, at least in some parts, like in this focus. And here, nothing in the fat, but highly suspicious. So highly suspicious also because here is another area, again, very concerning for invasion. And we call this invasive carcinoma. The case also had an additional slide I didn't tell you about. And this is a cytology fine needle aspiration slide that came from a bone lesion, and the patient had metastatic carcinoma. So in this case, unfortunately, the misdiagnosis of intraductal papilloma that was necrotic led to the patient, you know, not being properly treated at that time for an encapsulated papillary carcinoma. And she ended up developing a recurrence and metastasis. So these are not, you know, don't give the diagnosis of papilloma lightly. And yeah. A benign papilloma, yes. That's typically age matters, as I always say, unfortunately. And so in older patients, think about a carcinoma, a papillary carcinoma, before you default to a papilloma. This is another case. Oh, no. Yes. There was invasion, and how did you keep the staging? I mean, you keep all the lesion or just the comfort of invasion? I think in this case, we kind of used a minimal commitment type of approach. We said that there was invasion, difficult to quantify. Sometimes I say that it's true. Also, many times we receive 2 slides, and it had been called invasive outside also. So they had gotten that part correct. And we went with that diagnosis. So and the other good thing for us on submitted cases, we don't stage because we don't have the entire material, but I would have staged it, I don't know, let's say 5 millimeter of invasion plus this large mass. I would have said, you know, T1A plus there is, you know, a large mass of papillary carcinoma of uncertain nature, something like that, you know. We are very hesitant to change the diagnosis of all cases in particular, but in this case, honestly, I think I might have called the papilloma, the infarcted EPC, atypical papilloma, and just to let, you know, not to stir the pot too much and cause trouble. Sometimes we do that. And then I have another case, a 70-year-old with a breast mass. This is the only SPC. Well, I shouldn't have said case. Oops. Here is another case where we have a solid proliferation with 2 nodules. Notice there is a capsule also, oops, around this proliferation. There is a thick, you know, fibrous band all around it, more prominent in some areas like this, but it's also present up here, right? And then there are fibrovascular cores, edematous in this area, more, you know, with foamy histiocytes. In other areas, the fibrovascular cores are really inconspicuous. You really have to hunt to find them and look for red blood cells and use those to guide you to find the fibrovascular cores. Some of these cells are palisading around the fibrovascular cores. Here is a nice example of palisading of the nuclei. And the cells also have this grayish quality of the cytoplasm that correlates with mucin production, but there was no mucin outside in the stroma, although I'm sure you can see some little blobs of mucin also in the lesion. Here is monotonous cells, low-grade nuclei, and then the quality of the cytoplasm. And here is, you know, the presence of the mucin in these spaces. Again, mucin in this setting is a great tip-off. This is a solid papillary carcinoma, but there is none outside. However, there is some irregularity here and there, and so this is not a smooth outline of an SPC in situ. Is there invasion? And sometimes it can be difficult. Here in particular, I think there is a beginning of invasion, and there is some irregularity. And then you see these strands of tumor cells that are all alone in the stroma. Even this cluster seems to be, you know, on its own. It's not aligned with the rest of the lesion. Another area where the outline is irregular, and I think that's the main focus. But irregularities are present throughout. And this is a tough case because overall it's here in particular, this is the best focus we'll see in the stains. This is a case where, you know, overall it's nodular. There is a big round, somewhat round structure, but and the patient is old. Do we want to call it invasive and give her, you know, a diagnosis of invasive carcinoma or not? Luckily, over age 65, at least at our center, they no longer do axillary sentinel lymph node biopsy. So here is an ER clearly positive, and here is that area that looks irregular. So smoother in other areas that could probably still qualify as in situ, but there is too much irregularity in other areas. And here is another spot that appeared in the deeper, you know, in the immunohistochemical stains that show some microinvasion. And here is another area. So we call this case solid papillary carcinoma with invasion. And here is the staining with the triple stain. So P63 nuclei would be positive, brown. The tumor is all red, except for these few scattered brown cells. I never know what they are. What they are. They shouldn't be there. I'm always puzzled. But there is no myepithelium throughout, and there is clearly evidence of at least a microinvasion. So in this particular case, we call this case microinvasive EPC. Here is another focus. SPC, yes, sorry. Do you agree? Would you have called the entire lesion?
This one is the sort of one I struggle with because it's very rounded.
So the question is whether it's all invasive or only focally. And again, sometimes because of, microinvasion was, I have two more cases, but maybe we need to stop. What do you want? Oh, yeah. Okay, I have the energy. I didn't know if we were on time. This is another, yes.
Do you, in your routine, do you use multiple sections to do multiple sections to confirm or to
like deeper sections?
Yeah,
I mean,
at different
sections?
levels? Yeah,
Yeah, sometimes
for this type of lesions,
for these
papillary,
lesions,
yeah.
You know, sometimes I guess you may say I'm lazy. I think immunostains are faster to read than having to hunt around for, you know, in 3 levels, and then every level has its own new finding, and what do I do with it? So in a case like in general, I prefer to resort to immunostains that I think is more definitive in many cases. It depends. If I'm sure that that's what it is and I want to confirm it further, with levels will be fine. But if I really, you know, don't know exactly what is there, then I may do immunostains because I think they're more reliable, at least in my experience. And they will stand better in court, for example, if there is a litigation. That's my approach. Yeah. Yeah, that actually is always recommended. I do the H&E at the end in every case where I do immunostains. If the findings are small, if there is, I'm looking for microinvasion, well, that focus of microinvasion may be gone in the deeper section, but there may be 3 others that show up in other areas, right? So an H&E, you know, at the same level is always very useful. But the level sections, it's a lot to look at. I don't know. What's your approach?
These kinds of challenges.
I wonder, you said these lesions seem, well, having a mostly thick capsule, they remind me a lot of, for example, thyroid follicular lesions. So in my very limited experience, at least in the thyroid lesions, levels, H&E levels are what is most useful to find and to decide if there is a capsular invasion or not. Wouldn't it be useful in this case too? Because besides the one that seemed to have a very thin line of epithelium around the main rounded lesion, the other one seemed to have like a little arm that looked like it could rejoin the rest of the main ball, so to speak. And I'd wonder if deeper section could have showed something to that extent.
Like you mean here, the arm that could rejoin this side? I don't know, That's an interesting question, but in general, in breast pathologists, at least, they, you know, I don't do thyroid anymore, but I wonder if you have more a focal point of invasion through the capsule that is usually limited to one focus. Yeah. Here, there are multiple areas where, you know, we were wondering, there was some irregularity. And in general, the approach, at least for breast pathologists, is to do myepithelial stains and look at these. Here, for example, this focus for me is also very suspicious for invasion. And I think that's probably how the solid papillary carcinoma grows. It kind of grows around the fibrovascular core, induces angiogenesis and grows around it and swallows it and forms this solid, big expansile mass. Here there is another focus. I don't think I could see all these tiny, tiny foci of possible microinvasion in an H&E with confidence. So in general, our approach is to do immunostain. Not on every block, but at least in some of the cases. So I have two more cases. This one is an example, is a very unusual case, and the patient, unusual because the patient is 20-year-old, and this was the only patient with Pezcoller syndrome that I ever encountered. And I received the slides of an excision of a breast mass under the nipple. And so this was concerning because what am I going to call this lesion in a 20-year-old? Well, there was not much to worry about in terms of the diagnosis. It's a large lesion with, you know, this papillary arrangement, mass forming, and very solid areas with necrosis, calcifications. And here is a papilla with, again, necrosis and calcifications. It looks like a high-grade papillary carcinoma overall. And there are many mitoses that were easy to identify in this proliferation. And you know, in this case, is it in situ? Is it invasive? I thought that part of it at least was invasive. For example, up here, I think this area looks invasive. There is retraction around the ducts that we don't see around the nest. We don't see that here. There is irregularity. This could not be in situ. Maybe there is an early invasion even here. Retraction is quite common around an invasive carcinoma, while the in situ tends to be more cohesive and adherent to the wall, you know, to the rest of the tissue. Like, for example, this I would expect to be in situ, but at the periphery, there were some areas like here, I was very concerned there was invasion. I thought the whole thing maybe is invasive or is there in situ as well. So in this case, I did my epithelial stains. You know, you have to remember that we don't do myepithelial stains on every case, but the case I brought, just for illustrate the point, also have myepithelial stains. And this one is, I believe, a calponin stain that highlights areas of CK56, sorry. That highlights some myepithelial cells all around this proliferation. And here is another area where there is no positivity. There is some positivity in some of these clusters, but it's quite interesting. This tumor that looked so high grade and basaloid doesn't seem to be very positive for for CK56. Here is a beautiful focus with in situ, and then it branches out and we have invasion. So there was a clearly invasive carcinoma. And here is that focus I showed you before with the trilobed appearance, all invasive. So this one maybe P63, I would think. Yes, the same type of pattern. There were some areas with in situ and some areas without any myepithelial staining that clearly were invasive. So I thought it was an unusual, and this is the ADH5 I mentioned before, mostly a red tumor with some P63 positive cells that are still present at the periphery, the focus of in situ carcinoma with central necrosis. And again, there is the invasive focus, I thought it was up here, where the cells, you know, this three-lobed focus, so there is more invasion. So I thought this was an unusual example, a good example of invasive, somewhat papillary carcinoma with still associated DCIS in a very unusual clinical setting, given that I have never seen a case in a patient with Pezcoller before. And it turns out the following week I received a biopsy also from the other side, and there was another atypical neoplastic, at least DCIS proliferation. The patient underwent bilateral mastectomy. So I was not even aware of that fact that Pezcoller patients may get breast cancer. So an example, and this is the case. And then I have the last case, and that requires at least 10 minutes, but it's pretty interesting, so I want to show you. 50-year-old female with a breast mass. It says here not shown, but I found the biopsy. So we're going to look at the biopsy first. This is a case that came from outside, and here is the case, the core biopsy. You know, there is a lot of papillary proliferation. There are some areas that look like UDH right here, right? Very disorganized, the pink cells. There is more strange arrangement around some of these papillae, right? And here there is, I did not, you know, put a note for this case. We have some histiocytes, foamy histiocytes in some of these fibrovascular cores with a great, you know, expansive proliferation of epithelium that looks like UDH. Not very atypical, to tell you the truth. So, and then there are these weird papillae with, you know, monostratified epithelium. So what was this called? Leukocyma, a tall cell. But would you have called it tall cell on the core? You would have called it. You're very brave. We called it a typical papilloma. We really, you know, some areas have UDH-like growth. Well, we were hesitant to call it as a carcinoma because these areas had a pattern that looks like UDH. The case I showed you before of tall cell carcinoma with reversal polarity does not look like this. It's a very confined, you know, proliferation, very regular, does not have any epithelial hyperplasia. So I'll show you the excision. This is the excision. And again, it's a very nodular lesion with, you know, a lot of somewhat papillary with fibrovascular cores, very prominent edematous in some areas. And here there are some tiny calcifications. Yeah, you can see some grooves in some of these cells. Here the proliferation has reverse polarity in some areas, but not here. This is unusual. Here in some areas almost looks like it has secretory change. There is this eosinophilic colloid-like material that is present. Cell borders are evident in some areas. The nuclei are overlapping with nucleoli. Is it atypical? A little bit, but you know, what do we call this lesion? Beautiful reverse polarity around this fibrovascular course. Here is another area, again, reminiscent of thyroid, secretory carcinoma, more calcifications, and again, beautiful reverse polarity. And here is another area that has a lot of fibrovascular course and the reverse polarity, but then in between there is this epithelial proliferation that looks like UDH, to me at least. So here is another area, some fibrovascular course surrounded by cells with reverse polarity. Some of it looks like UDH. So is this a tall cell carcinoma with reverse polarity, an unusual morphology? Is it UDH with the carcinoma on top of it? Is it all cancer? There was one area that had the typical morphology. This was easy to identify. This looks like the picture I showed you before with this zipper look of the two layers of cells on opposing papillae that have reverse polarity. The nuclei line up close to one another. It looks like a little zipper to me, a little bit. But so we didn't know exactly how to call this. We recognized there was definitely tall cell carcinoma with reverse polarity, typical morphology. But the rest of the lesion, was it a carcinoma? Here is ER negative in this area. Conventional morphology should be negative, can be negative. Another area right here is coming in focus, focal positivity. Another area that looks like UDH-like area, practically ER negative when it comes in focus. There is no staining, maybe one nucleus. So a strange tumor, maybe that's not UDH, right? Is a UDH-like lesion. This one is also more ER positivity in some other areas. So there is a heterogeneity of staining for ER in this tumor. And then here is CK56. And the typical area, once it comes in focus, I don't know why. It's ready for lunch, I'm sorry. Is typically staining quite strongly as expected, but some other areas have a very wispy single cell staining. It's not like UDH, but it's staining in a funny manner. And some other areas almost could be UDH, right? There is a more mosaic type of staining. So this was a case, I told you before that there is a molecular alteration that identifies is characteristic of tall cell carcinoma with reverse polarity. And there is also immunohistochemistry that can be used to detect it. So we did both. Molecular alteration demonstrated that all the tumor was a tall cell carcinoma with reverse polarity, and this is ADH5, I'll skip. Immunostain for IDH2 R172 shows positivity throughout the tumor in the typical areas and also in these areas that look like UDH. That's pretty neat, I thought. And here is another area. And I have actually, this is the negative, the normal ducts do not stain, they don't have the mutation, so it's very specific. The other interesting finding is that we found the foci of true invasion at the periphery of this tumor. A couple of areas where, there is, doesn't have that rounded outline, but it has this peripheral infiltration. And this was not due to the biopsy because there were other foci right there. And they're positive, so that is also tumor. And maybe we haven't learned everything about these tumors yet. That is a very good question. This was a difficult case. I know the patient, we gave with a long note with a description. This is an unusual tumor, low grade. We asked that the patient would not be treated with chemo because we thought it was very low grade. But it's a risky thing to say, to tell you the truth, because we really don't know how common these are. And, you know, definitely there is invasion at the periphery. This is the second case that I've seen with this finding. The immunohistochemical stain for ADH5 also highlights this, you know, scattering of small glands in the same location. And if you go back to the H&E, you will be able to see those same glands in the same location. Of course, I cannot find it now. Yeah, there it is. So in this area, for example, there are little glands that get lost in this big mass, but they are there. You know, this epithelial proliferation that is infiltrated is present here too. And the same also in other areas up here. So I thought that this was a unique case of a new entity with a new, you know, slightly different morphology. So here is another focus. Here, a little nest away from the tumor. All right, I think that's my last case.